Psychiatry, psychology. All right, so first off, we're going to be talking about classical conditioning. You know classical conditioning is Pavlov's dog, all right? It's very easy and straightforward. Just remember on when he did the classical conditioning to the dog, he incited a involuntary response, which was the dog salivating, okay? So that's what he wanted to do. He wanted to ring the bell in order to connect ringing the bell to feeding food. And so at one point, as he continued with the experiment, ringing the bell just elicited an involuntary response of salivating by the dog. So what you want to know for classical conditioning is that it elicits an involuntary response, okay? For operant conditioning, this elicits a voluntary response, okay? And we have two types. We have reinforcement and we have punishment. What you need to take away is that reinforcement is going to increase behavior, while as punishment leads to decreasing behavior. Okay, so that's the whole entire point. Like that's the end all be all is for operant conditioning. It's eliciting a voluntary response. And whether that voluntary response increases behavior, it's a reinforcement. But if it decreases behavior, then it's a punishment. Okay. And whether it's positive or negative is telling you whether you're adding a stimulus or you're removing a stimulus. Okay. So if you add a stimulus and you get increased behavior, it's positive reinforcement. And then same goes if you add a behavior or if you add a stimulus and you have decreased behavior, that's positive punishment. And then opposite, for removing a stimulus and having increased behavior, you get negative reinforcement. And then removing a stimulus with decreased behavior, that's negative punishment. Because remember, overall reinforcement just means increasing behavior. And then adding a stimulus just means positive. Punishment means decreasing behavior. And removing a stimulus means negative. All right? Very straightforward. It isn't too hard. Next is transference and countertransference. What they want you to know is that just transference is when a patient projects feelings onto the physician. Okay? So they put the physician... and they connect it to their personal life or personal problems. And that's transference. They transfer it specifically to the physician, like the psychiatrist that the patient is seeing, okay? And so transference is just placing or projecting the feelings onto a specific physician. It has to be a physician to make it transference. Countertransference is when the physician themselves project their feelings onto their patient. So if they see their patient reminding them of potentially a younger sibling or their parent, that's countertransference, okay? Projecting a physician's feelings onto their patient, okay? Now remember, transference and countertransference only is like in the realm of the medical field, like in the realm of physicians, okay? So there's other different types of things that we'll learn that are similar to transference, but they don't involve physicians. This is a very niche topic. Next is our ego defenses. For the ego defenses, I'm just going to be kind of picking out the ones that are relatively higher yield that I had a lot more questions upon. But going through each one of them can be helpful, not too much, because once again, it's not too high yield, but they're very easy. So it's not something that's like monotonous for you to go through. The first one that I think is very high yield is displacement, okay? Displacement is, once again, redirection of emotions or impulses to a neutral person, okay? So, remember that transference is essentially redirection of emotions or impulses onto the physician, but that's not a neutral person, okay? Displacement is redirection of emotions to a neutral person, okay? So for example, this is one common example that they like to talk about for displacement. Let's say you get punished for doing poor at your job, okay? And so you go home and you start critiquing your girlfriend in the way that she's doing specifically something. She has nothing to do with the reason that you're mad, but you're displacing your anger or emotions onto her. She's a neutral person, okay? You're really mad at at the boss that told you that you're not doing well at your job. So you come home and you displace it on a neutral person like your girlfriend. All right. Next is going to be passive aggression. So passive aggression is very easy to understand. We see it all the time, but it's demonstrating a hostile feeling in a non-confrontational manner, right? Very easy. I know a lot of people that have this, but essentially all that you're doing is that you're mad at somebody and you display it in a manner that's non-aggressive, okay? So a disgruntled employee is repeatedly late to work, but won't admit that it is due to the fact to get back at the manager, okay? So they're not actively seeking out aggression at the manager, okay? But they're showing it in different manners for being late, okay? Next would be reaction formation. They love reaction formation. Reaction formation is essentially replacing an idea or feeling with an emphasis on its opposite. Okay, so what does that mean? That means that, like, for example, if you have like a stepfather who really just hates his child, okay? A stepfather really hates his stepson, all right? But he treats the child in complete opposite manner. He's very excessive when he's he's very excessive in his loving towards him. He's very nurturing and he's overprotective in like in an outward way. But secretly, he really cannot stand his stepson. Okay, that's reaction formation and it's high yield. Okay, next is splitting. Okay, splitting is believing that people are either all good or all bad. And that is a black or white issue. Okay, so that's how I remember it. It's a black or white problem. All right. And so like they can't see that there's gray areas places. Everything has to be black or white. People are either good or bad. All right. And this is very common in borderline personality disorder. Okay. So for example, a patient that says all nurses are cold and insensitive, but all physicians are warm and friendly. Okay. That is splitting. That's making everything black or white. There's no gray area. Okay. And then for the mature defenses, the one that they like to talk about is suppression. So suppression is going to be intentionally withholding or pushing down an idea or feeling from conscious awareness. Okay. So for an example, an athlete focuses on other tasks to prevent worrying about an important upcoming match. Okay. So they know that they're doing it. Like for example, when you're studying for step one, you can try to go outside and play soccer to kind of keep your mind distracted, consciously distracted. You're intentionally doing it to kind of get away from studying for step one. That's suppression. And that's a healthy mechanism of defense. Okay. Very healthy. Now, kind of a opposite to it that they like to compare is repression. So repression is an ego defense that's not too healthy. It's involuntary. So the patient doesn't know that they're involuntarily withholding an idea or feeling from conscious awareness. Okay, compared to suppression, they're intentionally doing it. Repression, they're involuntarily doing it. They don't notice it. So this would be like a 20-year-old does not remember going to counseling during his parents' divorce 10 years earlier. He's suppressing that, misuse of the word. He's repressing that memory involuntarily. Okay, he's not suppressing it to help him in the future. He's not intentionally doing it. All right. Next for our psychology is grief. So grief, once again, it's normal. Okay, it's a normal, natural feeling that occurs after you have lost a loved one. Okay. Now, normal grief, what they want you to take away from it is that it does not present with pervasive anhedonia, worthlessness, or suicidality. That's abnormal. Okay. So for a patient to be experiencing grief, they should not be experiencing like severe anhedonia, worthlessness, and suicidality. That's a more severe pathology. Okay. For it to be grief, usually it's going to be limited by time. So like within 6 months, it's not a disorder, but you're expected to grieve for, severe grief for 6 months. But if it's ever experienced with that pervasive anhedonia, worthlessness, and suicidality, then it no longer is grief. Okay. Very important to know that. And lastly, I'm going to be talking about normal infant and child development. This, to me, is going to be a waste of your time. If you care a lot about psychology and psychiatry, take time to read it and know it. You're probably going to get about 5 questions on it throughout all of your U-World studying, and maybe one question on one of the NBMEs or CBSEs. They can ask questions on this, so it's not completely low yield or out of yield, but it's something that I think takes too much time to memorize and it doesn't give you a lot in return. Okay. So here's a couple key takeaways for me. First key takeaway that I want to kind of emphasize is that your words, okay? They like to ask about speaking. All right. So if you have failure to say greater than or equal to 3 words at 18 months, it indicates a language delay. Okay. You have to have 200 words by 2 years and then 300 words by 3 years. Okay. So that's kind of one of the key takeaways that they like to talk about. And then another one is stranger anxiety. So kids are normally going to have anxiety towards strangers. And that's a normal thing from 6 months to 2 years. Okay. So keep that in the back of your mind when talking about normal infant and child development. But other than that, honestly, it's to each your own. So, if you want to do well, very, very high scoring and you really like psychiatry, then by all means go for it.